Okay,
Good morning.
good morning from New York and good evening with the last session of the Hyderabad Live, day one. Can you see us and are we fully audible?
Good morning, Samin. You are very well audible. And this is Anand here, Anand Raman. And I'm joined by sort of esteemed panel members, Helen from Rouen, and Dr. Gokhale, Dr. Chopra, Jan Mohammed, Manik Chopra, sir, and Mantosh, R.K. Jain, Ram Kumari, Sarat Chandra, sir, and Sridhar Kasuri and Tripti Dev will be joining later. So fantastic. And with that, without further ado, please go ahead and introduce your team and also the case,
Yes.
please.
Beautiful. All right, Anand, clearly from Mount Sinai, thanks to our Hyderabad Live organizers and Dr. P.C. Rath, give this opportunity. And I know it's the case number 7. It's the last case of the day. Then they have your evening celebration. But we'll make it a little different way. I know 6 cases already been presented live today there, and I'm so happy to see that 16 live cases will be done in those 2 days. With that note, myself, Dr. Samin Sharma, Director of Interventional Cardiology here at Mount Sinai. Dr. Sahil Khera is the Director of Structural Intervention at Mount Sinai. Then Dr. Anpurna Kini, Anu, is the Director of Interventional Structural Heart Program for the health system. Then we have Dr. Gilbert Tang. He is the Surgical Director of Structural Heart Program for the health system. Then we have 2 fellows, Manish and Anoop. And of course, the cath lab staff, and then Dr. Stem Larakas is on the echo, you'll hear him, and Dr. Fried also on anesthesia. So this is a case which is a little different in the sense that what we want to show is initially we actually had a plan for valve in valve. That is what PC Rath wanted, but that patient had a little trouble. So we have the case with a high creatinine, and we have published that how can you do with no contrast TAVI. So that will be the goal of today. With that note, and I know the great panel will need a lot of help, and we start our presentation with the case discussion. Show it slides, please. So these are our faculty involved here, shown everyone, and this is the case number 7, 87-year-old who has heart failure and syncopal episode, AFib on various medication. Creatinine used to be 2.3. Fortunately, today creatinine is 1.8. So if we need to give 5-10 cc's, we'll be okay. Otherwise, patient has a moderate to severe decreased LV function, 30% with a severe low flow, low gradient aortic stenosis. And I'll ask now Dr. Larakas to show us the live echo.
Yes, good afternoon. I have on my left Yov, our structural imaging fellow. As you can see, this is a 4-chamber view. The EF is about 35 to 40% today, mildly decreased RV function. X-plane of the ventricle, again, about 35% RV mildly decreased. Not much mitral regurgitation. The pacemaker wire on the right ventricle and mild tricuspid regurgitation. This is the aortic valve long axis view. As you can see, severely degenerated valve, thick and calcified with decreased mobility of the leaflets. X-plane, tri-leaflet aortic valve, severely restricted motion of the leaflets, severe aortic stenosis, minimal aortic regurgitation. This is the deep gastric views. As you can see, the leaflets, thick and calcified, decreased mobility, severely stenotic valve, turbulent flow through the stenosis, minimal aortic regurgitation. The maximum gradient that we get today is 29 millimeters mercury, mean gradient of 16 millimeters mercury, peak velocity 2.7 meters per second. This is the TVI of the LVOT. If we put everything together, we get aortic valve area of 0.88 centimeters square, severe aortic stenosis, and stroke volume index of 28 ml per meter square. This is a classic low flow, low gradient aortic stenosis SVI index less than 35 ml per meter square. And this is a 3D image of the annulus, where we get an area of 7.5 centimeters square, diameter of 3.5, maximal diameter, a minimal diameter of 2.5, and area of circumference area of 10.4 centimeter. Thank you very much.
Okay, so clearly that area of the echo also is important to decide which kind of valve we are going to go. And this is actually what we are going to show. how to do these cases. We have done cases with a creatinine of 4, 5 even. So we use both cardiac MR and non-contrast CT. So this, and I'll show you both which are done in these patients in terms of annulus, LVOT, coronary heights and all. So this is the cardiac MR, and I'll ask Gilbert to talk about that now.
Yeah, so the cardiac MR is non-contrast, so it's not a contrast cardiac MR, number one. Number two, you can see that the annulus, if you have no motion artery, it's actually quite well delineated in the LVOT, and you can see this is a big patient actually. So STEM show the TE measurement, usually with TE and CTT can be a little underestimated. So you can see the CT is actually, look, it's quite generous anatomy, perimeter 91, area 634, and you can see LVOT consistent because the low ejection fraction, large ventricle, so the LVOT is expected to be larger like you see here. Next slide.
And perimeter is quite 91.
Yeah.
And so this is the cardiac. Now this is the CTA.
That's right.
Non-contrast.
So CT non-con is difficult sometimes because you don't have the delineation, but sometimes you can base on this calcium distribution to actually get a rough estimate. This is not exact, but in this case, actually, thankfully, there's a bit of motion artifact, but the annulus is preserved. You can see pretty much similar in measurement as well, pretty consistent.
Yeah, see that both of them are similar. To the mean about 28.5 and same we had 28.6.
That's right.
And parameter of about 91. So consistent. Now go to the next point, cardiac MR for the root analysis, which is clearly here. And same we did the CTA root analysis. Again.
Yeah, the CT, remember, MRI, you cannot see the calcium, right? So you use the CT to look at the severity of the leaflet calcification, and it correlates very nicely with Stam's pictures on the tri-leaflet aortic stenosis with this calcium. And you draw a circle to essentially see how a valve may potentially fit in this anatomy, because you don't want complication, obviously, because you don't have a contrast.
Okay, so then now we go to sinus tubular junction and SOV, sinus of Valsalva, and same cardiac MR, about same maximum, minimum, and SOV diameter, and the same thing we got on the CTA. Just to say, very consistent findings on both CTA and MR. Then sinus height and coronary, which is very, very important, because that is what we know, that one of the complications of the TAVI, that you could have a coronary obstruction. So since you're not given any dye, we did the coronary angiogram with a 8 cc dye left and right back in the few weeks ago. Coronaries are non-obstructive, but still you have to worry about the coronary heights, which is generous, good. Left 21, right 25 with a sinus of Valsalva height of 30.
Yeah, and you can see that here. So there's a very big root, and you can, if you see the next slide, there's actually some motion artifact on the non-con CT. You can see there was an upper on the aortic root. That's why you see the measurements a little bit different. But that's very key, that if you do a non-con CT, make sure there's no motion artifact. You can do it in the diastolic phase. Instead of systolic phase, you can do it gated however way you want, but make sure there's no motion artifact. Otherwise, the measurement will not be accurate.
Good. So now we go to the last one, the aortic root angle, that it just shows very horizontal aorta.
It is quite horizontal. You can see that here on fluoro as well. So
yeah, and we'll show you on the fluoro. And these are our basically calcification on the CTA with the hockey puck sign, and just to looking at the valve with the high calcium. And now this is again non-contrast CTA for the access anatomy.
Yeah, non-contrast is not very bad for access anatomy. It just takes a little bit more time to sort of delineate the center line of the vessel. But you can see it's relatively large bore access sites on both. Patchy calcification, especially the iliac on the left, is very calcified. So I think right perc mid-femoral stick should get us the best results here.
yeah, one point I think, Sahil, you agree, right? That there's sometimes blooming artifact on the calcium.
Yeah,
so you have to be careful that the lumen may be actually smaller than what you think it really is.
That is true. So if you look at the circumferential, if you have more than 270 thick chunk of calcium in a vessel, that it could falsely give you an impression that the lumen is big enough, but you can have a blooming artifact and struggle with that. So
now in some of these cases, and I think that's a part of the discussion will be the panel, should we do an ultrasound? I mean, IVUS of the femoral and iliac arteries to decide the size, or this non-contrast, those MRI and the CT is good enough?
So we've looked at, not flight MRA abdomen pelvis too, right? The issue is that it doesn't delineate calcium, just like the issue with MRI of the annulus. So you might be, again, overestimating your true luminal diameter.
Okay.
No, that's the
Yeah.
reason he's asking. Is
So-
intravascular ultrasound, is it
So
going to help
Vanessa
us?
Hill, you want to comment on that?
Yeah, we've done 4 cases where I've done active intravascular ultrasound just for the access entry point.
Right.
So you can do fluoroscopy and IVUS, take a picture at the same time. You determine which is your best site for entry, especially in cases where you have a narrow margin of calcification. So we have used intravascular ultrasound for main access.
Okay, so let's come to the last. We are ready for the case. So this is the summary of the case. Patient with the low flow, low gradient. The basically actually should be risk mortality of 3.3. Patient evaluated for heart team because it's stage 4 and CKD, but although can't see creatinine a little better. The transfemoral tower with 34 millimeter evolute because of the high parameter, right? So evolute FX with the right, and we'll use the Sentinel EPS device and has a horizontal axis. So what we have done so far, just show it now quickly. We give 2 cc of dye for the femoral. Go to the angiogram, yeah.
You're getting the access here, right?
Same pre-close have been placed. Now, show comment on this
Yeah, so we don't want to give dye to look at the aortogram, right? Because you want to conserve contrast. So this is a technique that we developed over the last 6-7 years ago now. That where you use a pigtail and then the 2 pigtails or 1 pigtail of a J wire, however you want. This is what you see on the non-cusp and the right cusp. So that's a coplanar view, and you can actually see some calcium on the left cusp as well. So it looks very nicely. If you look at the next fluoro image. So then we use the cusp overlap. You have the non-cusp and the right cusp. And then if you look at this aerial caudal, and then now here, this is the money shot. How do you get the cusp overlap view without CT, right? Without any contrast. So you basically leave the pigtail in the right cusp, and then you put another wire or any kind of catheter into the left cusp, and you just simply overlap the two, and there your cusp overlap view. And then when you deploy the wire, you just put the pigtail back in the non-coronary cusp as you do it on a standard manner, and then you just do the procedure. So that's kind of will be a working view.
And next. And so clearly, since the Protect Tower trial, we used to use default of the Sentinel device. And now we use it in the selected cases. About 40%, used to be 68% at Sinai, but still people need. This patient has a high CHAD score and AFib. So this is where we decided to put a Sentinel. And actually Sentinel is very easy. And we know that many new devices are still coming, despite the negative or kind of, I would say, not that positive trial of the Protect Tower. Others are still ongoing, but we still use helpful, in my opinion, and that's the one. The disabling stroke is definitely decreased by using the Sentinel device, particularly in these high-risk cases. With that note, we are going to cross it, and you can have your discussion further while we are proceeding with the case. Anu?
Can
We
ask
actually
a
used
question? Helene Eltchaninoff.
AL guy.
Yes, sure. Any question, yeah.
What are your indications for the protection devices cerebral? Because you said high risk, but who are considered as high risk? And so what is your proportion of patients with Sentinel?
Beautiful. So Sahil will answer it because we actually have a paper, our research letter in publication, getting some. But Sahil, tell us which group of patients now we are using the Sentinel now.
Yeah, so these are patients who've demonstrated to be the highest risk of stroke. So bicuspid valve anatomies, valve-in-valve cases, patients with prior stroke, patients with a CHADS VASC more than 5, and patients who have heavily calcified valves. When your calcium scoring is more than 2,500, we tend to lean towards using Sentinel if we can.
So those are the ones. So just to say, earlier by default it was about 68%. Now number is about 1/3, about 30 to 33%. So every third case we are using it, and whether we'll change this practice by other data with the BCIS and other data will come. We'll see. But overall, I think it's the right thing to do. We learned that really you use it in a high-risk patient, and that's where you have a better benefit.
Is this
So those
based
are the
on the
5,
local
6 group,
experience? Samin? Is this based on the local experience?
Well, more important also, the whole review, the editorial about after the Protect trial. And so the question always came, what are the high-risk cases otherwise in the literature? I mean, one is our experience. Second is, what are the cases who developed the stroke after tower? Knowing that the number has gone down from 6% to 5% to 4% to now 2.2. Our TVT registry, all patients together in America, the stroke rate is 2.2%. Actually going down just around 2. And key is it's not dependent on the volume of the center or the operator, while everything else goes down, mortality, vascular complication, everything else goes down. down with the experience, but stroke rate remains, but still it has gone down to 2% and very happy. And so was noted in the
Yeah,
Protect trial.
and also to Dr. Sharma's point, if you look at the literature, atrial fibrillation, prior stroke, and bicuspid independent predictor for strokes, right? You saw the bicuspid paper, they all have higher strokes. AFib is demonstrated multiple times as an independent predictor for stroke. And so I think these are the patients I
Sure.
think would benefit.
No, the other
Okay,
question
Anu, go.
is, obviously you have demonstrated the zero contrast based on multiple modalities now. What we have practiced is a plain contrast without non-contrast, plain CT with a 3D echocardiogram. And that has proved useful for us. The addition of the MRI to this, how much additional information does it provide on top of your non-contrast CT and a good 3D echocardiogram? The MRI, what is the additional?
Yeah, that's a great question. And I think, thankfully, you guys have excellent echo operators because as you know, 3D TE in terms of sizing is quite operator dependent. Thankfully, we have Dr. Lorakis with us, who can measure this very accurately. So, and also non-contrast, as I mentioned before, depends on your artifact or motion artifact. And if you have not much calcification, such as a fibrotic valve, it's harder to delineate the annulus. I agree with you. MRI has to be can be compatible for MRI. Some of them have contraindications. But if we can, we would try to do that because we tend to have a good correlation between the non-con CT and MRI. In fact, if we're using a balloon expandable valve, for example, if we use the MRI and the annulus is a bit smaller, we'll be more conservative to avoid an annular rupture.
Yeah. So just to, I think, more consistent from the annular size. And we learned that the echo, original partner trial, remember they done with the, using with the echo, and then came out with a CT that become the gold standard to decrease the overall paravalvular leak and the selection of the valve. So question is, how much MR adds to what you have mentioned? Again, we are just trying to confirm it. And once we get a good number of cases, the last our presentation was about 8 cases or so, which we published in CCI. But if MR is really not helping us, and we see the similar data on the CT and echo, maybe we can avoid the MR because scheduling MRI, as you know, difficult. Almost 1/3 of them will not get it because of their pacemaker. Yeah. Already they have it. But so far we have been using both. And whole idea is to really learn from this combined approach that is it worthwhile adding MR into this equation. But
the other point is that you're absolutely right. So sometimes we do on-table TEE and just do a non-con if there's enough calcium to get an estimate of the annulus, and then we just confirm that at the time of the procedure.
Dr. Sharma, actually,
so that
is the stage 4 CKD and the low ejection fraction. Have you taken the protocol of hydration in this patient?
Yeah, so remember with that EF, you had to give very low. Yeah. So we admitted this patient day before. Usually patient comes same day. So we started him at a 0.5 cc per kilogram. Okay, so about 40 cc at and half normal saline, not the full normal, half normal saline since yesterday. So that actually led to this morning creatinine went down to 1.8. And from the 2.3, yes. So now, mucomist, people N-acetylcysteine, there is a lot of words about to use or not use it. People say not beneficial, but I can tell you it's a very, if not, it's a nice psychological or placebo. Patient feels better that we are doing something about their kidney protection. So we do use mucomist also, but definitely slow hydration in this patient, which we did for 12 hours, which led to a nice decrease in creatinine. And I hope after this valve replacement, creatinine may even get further better, which increase in the forward stroke volume and cardiac output. Because this patient about 2 years ago, his creatinine used to be 1.5. So yes, I had some CKD in the past, but not to the level of 2+. But yes, all those things were done in this particular case. That's why patient was admitted yesterday instead of just coming that morning. So Anu, tell us what we are doing now.
So we actually used, people have various techniques to cross the valve. We usually like AR catheter. So here, since the root was large, we used AL1. We were able to just cross the valve. And then we did do a BAV. So once you cross the valve with the AR, then you have to exchange with the pigtail so that you will have your wire
But
the
reason for
mid-cavity.
BAV is because of high calcium. What was the reason for BAV?
Yeah,
Yes,
we are
calcium,
going there.
high calcium score, and it's a 34 valve. So we try to avoid post-dilatation when possible. And the literature has shown that if you pre-dilate less, you post-dilate more. So,
So
What was the size
other
of the
thing
balloon?
also, the normal wire that we
20,
use
23,
is
22. Right?
yeah, normally
23
we
ZMAT.
22 ZMAT we did. Yes. Okay. No doubt.
Oh, so at the
Going,
bottom.
going.
Yeah. Here, that's the bottom. So you see, we put the pigtail all the way to the bottom of the non-cuss now. And now we're going to go to the cuss overlap. There was an LAO view just to confirm the head marker in the outer curve. This is the Evolut FX. For those of you not familiar, you can see the dots at the bottom. That's you can differentiate between that versus the Pro Plus platform.
And as you know, the FX is not available there in India, but I was told that by mid next year, you'll have it. So that really better delivery sheath and clearly that less movement of the valve
no
the
doubt,
forward and
no
backward.
doubt,
So
no
FX
doubt,
is a
no doubt.
definite new addition.
150, please. Just strike.
Yeah.
With Gilbert
You can
being
see
there,
we
it'll
have
be
a
better.
Lunderquist wire just
Yep.
because it is a 34.
Yep, okay. Now, Sinai.
Okay, you want to see
Yeah,
now?
and a little bit die. Yep.
Yes.
And
With Gilbert
this
being
the
there,
time you
it's
give
very
two
important
seasons.
if you highlight
Oh,
the commissioner
visualize.
alignment.
Good. Yeah. Beautiful. That's it.
Okay, you can see that, right? 80.
80, please.
You can see the dots there. One of the dots was in the outer curve, which is great, or inner curve rather. You can see that now. So this is let it sit for a minute. Just wait. Let the pressure come back up.
And you want to ask the echo tower stem that?
No,
how-
not yet. No, there's no need. You can see the pigtail has not moved. It's definitely at the bottom of the non. So you know the dot, in this case, the dots are 3 millimeters above the inflow. So you know that you're actually below the annulus already, even without dye. And so the key right now is to make sure you don't miss the left cuss. So that's where you need the dye injection before we
And you can see
start
the
with
outline of the
one
left
earlier.
and you can
vessel.
see a little bit of the height or the lucency. Dr. Kinney just did a dry Sinai, where you see the base of the leaflet start coming to above the inflow of the valve. So you know that you probably won't miss it, but we'll confirm obviously with contrast.
You want to
Okay,
give
you
two
want
more
to
CCs?
dye?
Yeah, just one more dye before we do that.
Two
I think
CCs
it's good.
only.
Yeah.
So aggregate, I call it a no contrast in our paper. What if it was done in single digit?
And you can see that. You can see that here. See the delay filling, everybody?
Yeah,
So
I'm impressed
TE up,
by
please.
the depth marker.
Yeah.
Yeah.
2
TE up,
CC for
please.
the femoral
Sorry?
and 2 and 2
TE up.
here. TE up. TE up.
Go on fluoro,
Good.
live
Please
fluoro.
now.
Go live fluoro.
TE up.
Good.
Yeah, good.
Okay.
Okay, I'm going to pull the wire
Pigtail
back.
and pigtail back.
Yep, Lundequist back. So this is the Lundequist. You have to remove the tension on the Lundequist to avoid the valve
Do it
completely.
on 180.
No,
Yeah, yeah.
it's not coming back.
That's fine. No, that's fine. That's fine. That's it.
Okay.
Okay. You're pushing forward.
Okay,
Okay.
good.
180.
So 180
We'll
pacing.
just wait. So this could be a slow release. 180.
Wait, let the blood
Okay.
go
Pressure
down.
is low now, so you want to make sure the valve is remain stable. So we typically deploy. Look forward.
You can see the
Yep.
buckle there.
Okay. Oh, it went. It dove in.
It went in.
It dove in. It dove in. It dove in. 120. Oh, we dove in.
That's okay. Push
Yeah,
the wire.
Okay. Push the wire.
Yeah, take it out.
It looks like jumped in.
It jumped into the ventricle. Leave the wire. Leave the wire.
Good.
Okay.
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 Back
All right.
to 80.
Back to 80, please. Okay. Stam, let's take a look. Really
Way
jumped
too
in.
far down.
It's really jumped in.
Okay.
You
Looks
get
like the large LV. It's
Yeah,
not
yeah.
terrible.
Not
Let's see-
terrible, yeah.
Let's see on the TE. Let's see how much PVL there is.
Bring the device to pull it up.
No. You have to put it.
Okay,
Okay,
some,
show the echo. Echo on the main screen.
valvular AI. No
Yeah.
much
Central AI.
central, yeah, central AI.
Okay, nothing paravalvular.
Mal para válvula, sí, mal para válvula.
Leave it.
Post dilate.
No. It'll move. Leave it.
Or should we put a second valve? That's
No.
the
No.
second question.
No.
Put a pigtail in. Let's check the hemodynamics.
Okay, let's walk it out there. Leave the wire in there. Leave the wire. Yep. Pigtail ready, please.
The question is, what are the other things we can do if we think it's a paravalvular leak, right? What is the biggest issue here right now? If there's no gradient, high chance of pacemaker.
It looks
No
like
conduction system changes.
I think during the last 1/3 of deployment,
Yeah,
you dive in. I'm not sure whether it's any
yeah.
ectopics or whether it's because of
No.
the rapidness.
I think it's large LVOT.
Large LVOT, it kind of jumped in.
Yeah.
Now, the options are you going to snare and bring it up a little bit, or are you going to allow it to expand and then reassess in terms of the gradient and the regurgitation? So at the moment, hemodynamics looks stable.
Very good, yes.
So,
For me, another problem is this is very advantageous because you selected right stent. In the self-expanding stent, chance of thrombosis will be less, and this self-expanding causing the less stress over the aortic wall, and then dissection would be less, and no fracture of the frame of the stent. That is very important issue.
Yep.
Do you believe it in this study? And overall, all causes of mortality to be significantly lower.
So question, but I mean, based on, let's flush both of them, 0.
so it's, as you can see here, I don't know if you have the echo.
Yeah.
It's significant. It's at
It's
least
what?
at least moderate.
Paravalvular?
Yeah, at least moderate PVL. At least moderate PVL.
Would you like to post-dilate it?
Yeah. Why don't you post dilate first? Or question is, I think better would be post dilate first.
No, but what are we achieving? It's the skirt is below.
No, but
We're
still,
posting it.
you decrease the PVL.
It's at that, it's not going to expand. Valve is
Now, Gilbert, what should we do now? PVL or another post dilate or another valve? That's the question. Do we put another valve or do a post dilatation? But post dilatation will require 26 or 28.
No, you have to.
There is still a PVL.
You would post dilate, but you would try to pull the valve more.
Or we just pull it, snare it up. That's the two things.
I think
No,
post-dilate at the
diastolic pressure
waist.
is low. Yeah.
Post-dilate at the waist, see if it makes annular contact because
let's do
there's
it.
leak around
28.
it.
I think we
And-
should post
and if
it
it helps,
take a,
post-dilate.
take a small
Then-
shoot.
Do you have a
on
30?
the stand. That
Yeah.
would probably
Yeah.
make us more wiser.
Yeah, exactly. We're going to
And
do that now.
give a safari wire. I think there
Yeah.
was no.
Now we'll use it for safari.
Yeah, safari wire, please.
Yeah.
You saw there was the nose cone wasn't moving and it just biases a lot.
Good.
You have a 30?
Safari, and then we use a 28 millimeter balloon.
30.
Huh? Okay.
30.
True balloon, yeah.
34
Well,
valve.
let's see what they have.
Which one we have? Yeah.
What are your plans now?
So two things we are doing. First, we are post dilating.
going to
Clearly, there is a
post-dilate.
moderate paravalvular leak, which we should not leave it. And the question comes to few options. One, post dilate, and they take a little aortogram that time. And if there's a question that do we snare or put another valve inside? So those are the two.
No, if you have to snare, you can't do it after post.
And what not adding
harder to dilate.
balloon expandable inside if there is a big
Yeah,
paravalvular
no,
Yeah.
that's what we are thinking, that if we need a second valve, will be a balloon expandable now. Yeah.
So we have 30?
Okay, 30 GMAD. We are going to dilate with a 30 GMAD.
You can unmute me again.
To call the
Yeah, so we'll use a 30 ZMAT,
people.
and we'll see if the valve can be brought a little bit more aortic
Yeah.
when we on the way up, when the pulse and see.
Yeah.
Samin,
But sometime it foreshorten.
Yes.
Samin,
They're calling.
Yeah.
Annapurna, can you hear me? Samin.
Yeah,
very
we
well,
can
yeah.
hear
We
you.
want to proceed and then probably another 10 minutes we can rejoin because we'll give you some freedom
Yes.
to
Yeah.
do post-dilatation, snaring, whatever need to be done. We'll
Yes.
have good discussion in the panel.
No, we can stay.
No, but we can stay because that's the last. You have any other lectures left or what? Tell me.
No, this is the last part of it. We'll have
Yeah,
a
No,
discussion.
we are
we just-
okay.
We are okay.
We are
Dilate
okay
now.
to be
You
live.
continue.
Yes,
Yeah,
yes,
you
we are
continue.
okay.
Yeah, that's fine.
Now, any
You're going to
comments
post-dilate
from,
now.
the
Yeah. Yeah.
Others or any questions, anything we'll discuss while they are getting on with the
Yeah.
case because they need to concentrate more at this point.
That's
Would
fine.
you,
And get the
would
snare
you
too.
probably,
I will
during
go with
I
the
need some help.
post-dilatation, try to pull the balloon slightly
Tee
up
up,
so that
tee up.
the valve tips?
Tee up, please.
Yeah, I
I
need
have
to
also
see
a
how the
comment
balloon is
between
going.
us,
Tee up.
More
when
up?
you
Okay.
not using contrast. I don't know what was the indication for selecting the core valve in comparison to the balloon expandable. With a marker, you can also, without contrast, position it quite
little
fast.
angulation there.
So I don't know. I have not coached
The question was
reason
balloon
for,
versus
core valve in
the
comparison
self-
to the
yeah.
balloon expandable. with a marker which is quite simple to implant.
The only reason I can think of is it gives you the flexibility of
180.
repositioning 3 or 4 times.
Yeah.
If you have the two
180.
pigtails in position, if you're not satisfied, you can reposition. But obviously, balloon expandable within good hands.
Can we have the blood
hands,
pressure a
on
little lower?
inflation, it's
Are we
fine.
okay?
Go.
Um,
Go.
The other thing is probably
Go.
it is also to demonstrate that this is a more of a horizontal aorta. The FX works
Because
well
of the horizontal,
because the original sort of pro and evolute, sometimes it's more than 67, 70 degrees.
Continue.
You have to use
Continue.
assisted
Don't do
techniques
anything.
like
Don't-
snare
I'll
or
do it.
whatever it is to bring it center. Here, that problem was resolved. The FX catheter is working fantastically
Okay,
well.
show it.
It went through
Off.
nicely.
Off.
Yeah, so question is clearly with the horizontal aorta, that was one of them, but yes, and heavily calcified. You saw that lot of calcium in this.
One
So
of the things we
question,
do in terms of the self-expanding valves
go
is
hemodynamics again.
it
Go.
gives you the freedom
Hemodynamics
of
again.
deploying 2/3 in a controlled manner, stop
Yep.
there, assess the hemodynamics, assess with echo. You have enough time. You take your time. And even though we don't recommend pacing, but in these particular cases where there's a chance of a large LVOT, you pace at a reasonable rate. You don't need to pace 180. You pace at 120, 130. Avoid any ectopics. Very, very slow deployment in the last
It's
one.
actually better.
Very
It's
slow
better.
deployment. Just one turn every sort of a few seconds. Allow it, the valve to
Diastolic is
self-expand
better.
on its own. And that will prevent this kind of sudden jump to the aorta or sudden jump to the LV. That is very much kind of what this needed. Otherwise, irrespective of all these things, it can still happen. The options you have here
Diastolic is much
you
better.
post dilate, you reduce the paravalvular
Let's
leak,
maybe done.
you
Don't do anything.
snare and
Done.
bring the
We're not
valve
doing
up.
anything.
Pigtail.
There is a
No,
small
not
risk
needed.
of the
Maybe
valve
nothing
popping
needed.
out to the
Nothing needed.
aorta. That's a
Yeah,
small
let's see.
risk.
Yeah.
Once you snared, if you're still having a paravalvular leak, then you go in and put a balloon expandable inside the self-expandable, a 29 Edwards,
exactly.
and that will sort it out. So it's a completely
that-
resolvable situation.
So
That is correct. So
definitely you're taking the right decision. After initial deployment, when they lower 1/3, is wait
Yeah.
a couple of minutes. You have to watch how the valve behave. So therefore, slow inflation, so deployment very essential for the
Shout
great
them,
result
flush.
and prevent the paravalvular leak as
Let
well.
me come in, guys. To flush this.
Yes, sir. I'm flushing.
Yeah. No, that is exactly. Remember, after 2/3, we did wait. Maybe we should have waited 5 minutes instead of 2 or 3 minutes.
Sir, how much
and the slow
contrast
deployment.
you use
Yeah.
it, sir, for entire procedure?
So far 8. Entire so far 8 cc's. 8. So now, okay, tell us the echo now.
Yes.
This is after 30 millimeter ZMAT balloon dilatation.
Yeah. So it's still a little bit better, but still, as you can see, moderate range PVL.
The diastolic is much better.
A little better, but yeah.
He says put the sapien valve. Just do it.
Okay. All right. So I think of the various options, pulling, snare, which we have always have to do associated with dissection. So as you mentioned just now, that probably the next step is, in order to avoid this PVL, take care of it, that put a 29 millimeter sapien inside. Everybody agrees? Panel,
Yes,
maybe.
we will agree. Yes,
Yeah.
we will agree.
Go quick.
Because the
Yeah.
skirt of
Okay,
the
we'll-
core
Yeah,
valve is
go.
too low, is too deep.
Yeah.
Let's do
Yes.
the aortogram first. Make sure
Yeah, we will.
take
We will.
corners.
Yeah. So we are
Can we
going to get
afford
that.
a, angiogram?
Yeah, we're going to do that right now. as
Tee
we
up,
speak.
please.
Yeah, tee up. You want to take the pigtail, LV pigtail, or put a wire there before you do
For the
aortogram?
landmarks
Yeah,
for
so
the
wait one
S3
second.
deployment,
No, but put the wire first before we do. Take the pigtail out, put the wire only, and make the. If you take a die, use the landmark where you are going to deploy the S3. We should do the aortogram in that position.
Maybe use the native coplanar.
Yep. So coming back to the point of one valve versus second, I think in this one, little choice, our self-expanding basically was the same. Use a lower contrast, one, horizontal aorta, two, and then the calcium, I think it was there, but not that much that we try to avoid balloon expandable in very high calcium. It was in the moderate range here. So that basically were the indications in this valve. We published the valve choice in JAMA Cardiology about 3-4 years ago. At Sinai, we doing about 45 TAVI per month, and it's about half and half, both Sapien and Evolute.
Yeah,
Okay, so
absolutely.
we are doing a...
It looked
Yeah.
fantastic.
Okay,
The
hold
way
it, hold
kind
it.
of flexed itself, the FX flexed itself in a horizontal aorta. That was wonderful.
Ready?
Too far down.
Some die.
You still die?
You're good, right? Okay. I'm going Sinai. Okay, inject. What happened, guys?
Prime it. Prime it.
Yeah, 29 valve, yeah.
Fluoro.
It's going?
Good. Yeah.
Pictil, you want to pull back a little bit, or
Yeah,
you're okay?
I will.
Yeah. Yeah,
Okay.
quite a bit. Yeah.
Okay. All right. Can we do 3,000 more heparin, please?
Yeah. So key is the snare. I can tell you we used to be a little more on the snare in the past, but we had a 2 aortic dissection with a snare. So we try to say that if there is an option of putting a self-expanding inside the situation, probably will be less traumatic or harmful for the patient. Although I know you can really pull it up. In this particular case, you can try, but those always have a little bit of a complication or issues with that, that maybe aortic dissections and so on, or maybe complete pop out. So easier will be put a 29 millimeter Sapien as said, and it will be ready in next 2-3 minutes. Same. This is the view we are going to do.
No, you are absolutely right, because this view you
Yes.
are showing, it's already showing that
Yeah.
the outflow of the core, the FX is hitting the aortic wall. So trying to pull the valve, it will cause trouble.
Trouble. Yeah, that's exactly correct. So it's... And post-dilatation did not do much, as we thought so also, that
I told you, it's not going
I
to
think
the
the
post-dilatation, we did it, yeah.
The phenomena for the paravalvular leak appears to be in-out. It's going through the cells because the covered portion of the FX is inside, below the annulus. So it's like the in-out phenomena.
Yep, that's right.
Yes.
Cheat.
That is correct. Absolutely.
ready. Is he ready?
Dilate the groin.
Good.
No. Is he ready?
E-sheath
Valve is
ready?
Okay, then.
Yeah, we have to change to the E sheath now. So that
Hold
another
the groin.
thing,
Yeah.
we have
No,
to change.
He's saying, do we balloon? Do we need to balloon? No, need.
No.
Who's saying?
Okay, let it flush.
I got wire?
Flush. No. Let,
One
bleed.
Leave it.
Bleed.
So
little bit.
anytime you
Okay.
change the sheath, we say that let the bleed because some clots are always there.
Mac out, please.
Who's saying balloon?
Okay.
All the way out so we can see the sheath insertion without losing the wire.
So we now have to
You're
see
now
both.
advancing the 16 French
E-sheath.
yes,
Yes,
from Edwards.
that's
Yes.
correct.
That
That's
is correct. That's what
Because
we are
the
doing it now.
valve is,
Flora?
it was over the wire.
18. Yeah, there was.
Yep. So this is now the Safari.
But the
Safari wire, right?
tolerance
Yeah.
of
this is a Safari wire.
regurgitation is good because we see the aortic pressure, which is fine.
Yeah. No, I mean, it is there. It's not a hemodynamically severe, but we know that these patients get into trouble.
Yes, of course.
So rather than, in the past, we used to be a little more conservative and don't do it. Now we do try to get results, particularly because it's a moderate PVL. It's not a minimal or mild.
Yeah.
Yeah.
Also, this patient started with minimal AI, so their ventricle will not likely tolerate the moderate in the setting of EF only 30%.
You have to tell them our pop-out numbers. I don't want them to think. Pop-out from Sinai.
Oh, in the back.
Very rare.
Yeah. Say it again now. What say?
No, our pop-out is so rare.
Yeah. No, but this is not the pop out. So again.
No, down or up, both is the same.
Yeah. So key is this
sizing, MRI
I can tell you
so hard to
acutely,
discern.
Okay,
Gilbert,
check
if you want to
orientation.
make a comment, orientation.
Yeah,
Check orientation?
we have the orientation
Good,
facing
okay.
down.
Good.
All right.
So I would say that the Sapien putting into the Evolute acutely. When did we do the last time?
I think 3 years ago.
3 years ago.
Yeah.
So key the overall pop out is about of the 500 cases maybe 1 or 2 per year. We have it, and no needed any surgery for many years now. And the last one we did Sapien inside the Evolute was almost 3 years ago.
Samin, sorry. The projection you are going to use and the pigtail marker, where is going to be? Can you guide us, please?
Yeah. We're going to
We,
the,
we
the
go,
pic-
we
with the
have
native.
we have the native anatomy. We just did the aortogram on the coplanar view that we
We're going
did
to go
before.
over that aogram
There
that
was
we
no
did.
parallax on the FX valve,
Hold on.
so we're
Let's
just
show
going to
them.
go look at it.
So this
Here.
is the aogram, if you can see.
You can see where the native anatomy, you can see where the coronaries are.
So that's
So-
what we are going to be using now.
So we're going to aim for that. So as if there was no FX there. So, because you want to see what the analyst and, yep, go
One
ahead.
second.
Here you go ahead.
Okay,
This is
go.
the 29 millimeter evolute. I'm
tw-
with
tw-
the Sapien.
Sapien.
Sapien going inside.
So now
Now
you have to
see
watch
the
this part.
entrance.
Yeah,
that
watch-
doesn't
watch
go
this
further.
part. Okay, watch the pigtail. Can you bring back the pigtail
Take the
first?
pigtail out.
Get a wire. Get a wire. No, not with that. Get a wire. It'll snap. Get a wire, please.
Hold on. No, hold on.
Yeah.
Wait a second.
Smoke it up.
Always have
Check
to
the
use a
pacing
wire.
Yeah.
to be sure that it's,
Yep.
it
Yeah.
works in
Even
perfect.
we'll check it again. Even last time we checked the rhythm. There was no issue with the. What happened to?
No, it was just.
You just always have to.
There
pull
was
back.
no
Yeah.
issue with the
No, what
pacemaker.
okay, wait. We'll need it again to go in.
Okay.
We may.
No, connect the
Can-
blood
can we
pressure. You
connect-
need
can
a
we
pressure.
connect blood pressure, please.
Okay.
Yeah.
Okay.
Good.
Little forward.
Go.
Yeah. No, we
Wait,
want.
wait.
So now
Let
pull
me
the wire.
flex
Yeah, let me see
completely.
1 second. Let me
Okay.
come in now.
I want to center the wire for you.
1 second. Yeah. Okay. We are trying to go a little slow.
Good, very slow. Good. Okay, good. That's it. Not too
Yeah.
deep. Yeah. Okay. I'm going to mag in now. Let's expose the hypo tube. So one thing you have to be very careful with the more ventricular positioning of the evolute is to avoid the interaction between the sapien and the evolute, so you don't end up giving even more ventricular on the sapien.
Give me the
Where's
wire.
Oh,
I wanted to leave that wire there.
you don't need it in the root. You have
Yeah.
No,
So
you need to
we
be
want to
there.
just bring the pigtail as kind of a marker, and
Yeah.
we already have that.
So Gilbert,
Pleural
correct me if
flate.
I'm wrong. You are going for a position as if you are going for a first-time balloon expandable in that native annulus and not worrying
Correct.
about at all about the other valve, right?
That is
No,
correct.
that's
Yeah.
exactly right. You don't want to be too aortic either, because you want to seal against the annulus, because remember the LVOT is also big.
Why
So,
did
and
you give me
also
this
you are
wire?
inside an
wire.
evolute frame. So the 29 is not going to go all the way to 29, right? Remember that. You're going to be constrained by the waist of the 34. So, but this will hopefully have more radial force to reduce the PVL. So we're not going to go like, 90-10 or 100-0 that you would use in a native anatomy,
Native
to
anatomy,
avoid
yeah.
pacemaker. Yeah, but you would do a little bit more ventricular to get a better seal and against the parabolic. That's the goal here.
Yeah.
Also, I mean, even if we are higher or lower in comparison to the native
Where's
annulus,
the pigtail?
the leaflets of the evolute are going to definitely give a good seal at all the levels. So even if
Yes,
we are
that's
low
correct.
or high,
You become
I
a
don't
tube.
think
Yeah,
we should
you'll
worry
become
much.
you'll become a tube grab, but obviously you don't want to miss the annulus.
Good.
Yeah.
That's it.
No,
Fine.
let's
But
see.
the
Let's see.
leaflets
No,
are
you-
anyway going
Good.
to stand whether we put it high or low.
Yeah.
little bit.
Okay,
wait.
180.
No, you're too in. I think.
Wait, we are not sure. You pull the balloon.
I will
But
go a
are
little
you
bit
using
more
the TE
ventricular.
guidance as well?
Yeah.
No.
We'll bring the T now.
Okay, look
Off.
Too
Yeah.
aortic. Too
Too
high. Too
aortic.
high.
Too high.
Too
Okay.
high.
Okay, hold on. Can we
We
go to
go.
the view?
No, too high. No, it's
No,
too
no.
high. You can
This is
see
the
it.
view.
You see it. Too high. We
This
are
is
at the
not
view.
the
We
view.
are at the view.
Yeah.
Too high. Too high. Good.
Yeah,
A little bit.
much
there.
better.
Yeah, good. There.
Good. Don't give any more dye. Good.
Yeah, that's it. That's it.
Okay, we're pulling back the pigtail.
Are you
Yeah.
sure?
Yes.
Yeah. Yeah.
Yes.
Good.
Yes. This is
Okay.
good.
Yep.
Okay. 180.
Yeah.
Okay, going up.
Yep.
Nice. All the way.
Good. All
Very
the way.
nice.
Yes. Excellent. Got it.
Wait. Don't do anything.
Keep pacing. Keep pacing.
Okay,
Oh,
off.
off.
Good.
We should hit it again.
Okay.
We could hit it again. We should hit it again.
Once again.
Yeah. We should hit it again.
Second dilatation.
Yeah.
Okay. So question is in this.
Pressure's good.
You
Stam?
want to see the
Yeah.
echo first quickly and
Yeah.
just
Stam,
do it one
go
more.
ahead. Stam, take a look.
Coming good. Diastole is more than 60, 70. So definitely the
Yep.
parallel could have reduced. You can see the two valves.
It seems that this
All right, two valves, stent in a stent sandwich,
Yeah,
same valve in a valve
It's
sandwich.
gone.
Yeah.
See, you can see,
It's
no,
gone.
no PPL.
No PVL.
No PVL.
Good.
Trivial, trivial if any.
Then do,
Do
then
once more.
Now that
Let's do
looks
hemodynamics.
very, very nice.
You
and
wanna
it
hit it?
looks
Not do it.
fantastically
You wanna
well.
hit it?
You can
Okay.
see the two valves,
Yeah.
no parallel leak.
Yeah.
And the hemodynamics,
Yeah.
the
You
You have to
diastolic
do it.
looks more
It's
than
like
60, 70.
two double
Sir,
stent.
Dr.
Let's do it.
Samin
Okay.
Sharma,
do
sir,
one.
So,
everybody
yes.
clocking
Yes.
at you. But one
Yeah,
question,
T
sir,
up, T
you
up.
kept
Yes.
valve in
T
valve.
up.
What is the
Yes.
anticoagulation in these patients?
Dr. Kini,
Yeah, that's
what
a
is
good
deep
point.
cell
No
changes
patient is
in
on
the
patient. Yeah, this
valve
particular
valve?
case, this patient is already on, Eliquis,
Yeah.
Apixaban.
For the AFib.
No, we're going
Yeah,
to look
and
more.
yeah. So
Can you
it's
flex
already
it
on
away, please?
Apixaban, but question is if not,
Unbelievable.
so we actually have been giving in those valve-in-valve acute cases, rare, as I said, situation, and same data comes out that when you do in
What happened?
TMVR,
Advance?
Inflated balloon can be hard to get in some cases.
that use anticoagulation if patient is not on there at
We
least
can't
for
go
3
then
months.
we don't do it. Okay,
Yeah,
good.
good.
Yeah.
Okay, we are going to do one more dilatation, just to, same thing like we do many times with the stent double dilatation. Here, just to get a little more better opposition.
A little bit deeper. Deeper.
Okay, I know,
Good.
I'm
Good. Good.
adjusting
Perfect.
it.
Perfect.
So,
But we can complete.
okay, good.
Yeah.
Hold it.
Yeah.
Okay, 180.
No,
Pigtail
not
ready?
yet.
Yeah, good. Pigtail ready?
Okay, I'm going up.
Yep.
Double inflation.
Yeah.
Now I'm
See?
able to hit it.
Do you guys see a difference in the because of the recoil against the evolute frame?
Yeah.
You see a little bit more expansion with the 29 inside.
Yeah,
Keep
absolutely,
pacing.
yeah.
Okay.
OFF.
Good.
Yeah.
Off. Okay. We can just do the echo with no more dye because
Yeah.
dye already have become
Yeah.
14 cc
Yeah.
now.
Let's take this
Okay.
out.
So just do the echo. Take the
Load the cap, load the
wire
cap,
out.
load the
Fluoro,
cap.
fluoro wire out.
No, let's can we do an exchange of a pigtail because now
Okay.
we have two valves in there.
Okay,
Let's
good.
do an exchange and we can do hemodynamics
Yeah.
again. Okay.
Yep.
I think it's important in this case. Let us know when you have wire. You have wire?
Yeah, we
Okay.
have.
All right. Okay. Pigtail, please.
Okay, show that echo again.
Yeah, Sam,
final.
please.
Yeah.
Sam, let's go to the pigtail inside. Show the hemodynamics so that we conclude day one of the Hyderabad valve with a little excitement. But again, it's like we thought that we'll make it exciting just without contrast, but it became even a different point. But
Yeah.
this is just to say that things do happen, but proper diagnosis, appropriateness, taking care of it. As I said, the pulling, which we used to do in the past, and particularly abutting of the valve against the aorta caused maybe more dissection. I think putting a sapien valve inside in this situation, which we did last one maybe about 3+ years ago, before our 1,1500 cases. Rare, but could happen. But I'm very happy that in terms of now there is no gradient. Diastolic pressure has gone up to about 60, 70. Flush the femoral also.
No, absolutely.
And,
I think there
you
is
can-
never a dull moment when you're doing tally, and that is a fantastic
Show the hemodynamics.
demonstration.
Yeah.
There is a fantastic demonstration
Hemodynamics.
of how you deal with it, and it's a fantastic result in the end, and how you managed within kind of 10 minutes of whatever happened, and making the decision of snare or not to snare, post-dilate or not to post-dilate, to go with another self-expanding or balloon expanding. These are all important decisions. Because you have a very experienced team around you, there are 4 of you are there, you made it look very simple. But otherwise, in inexperienced hands, this could be a major disaster. That's very, very well managed, fantastic case.
And thank you very much.
Very well salvaged, for sure. Congratulations. Is there any interaction with the mitral valve with the evolute?
You can show the T again. They
let
want
me
to see the
let me see
mitral
for
valve.
you guys. Let me see.
But
Yes.
we didn't see anything. Go back.
Yeah.
Yeah.
No much interaction. No much.
No, you can see it opening well. Put the color.
No much interaction.
Yeah,
I think
No
we are good.
MR.
Beautiful.
superb.
All right. Thank you very much.
Superb.
And thanks to the
and many
panel
congratulations
for
to
great
you all.
input. Beautiful.
Look at that. Look at that. See? Oh, this is the cut.
Thank you, Sharma and Dr. Kini and the team.
Thank you.
Congratulations. Thank you.
Great. Bye-bye.
Thank you, chairpersons, for conducting the meeting so well.
Eh?
Thank you so much.